Hello, good evening. Welcome to my IVF and the European Fertility Society. We are back once again. This is our second event this year so far. So thank you so much, everyone, for joining. I hope you are having a great evening and are ready to, for sure, ask some questions, but also ready to listen to our guest speaker today, Dr. Elena Santiago is right here with us. Thank you so much for joining, Dr. Elena. It's lovely to have you back because, of course, you've been with us before. And today you are representing Vida Fertility Institute, which is located in Madrid. So welcome. It's lovely to have you. How is your day going? And I hope you are ready to educate us and give us some tips on how to navigate IVF for women over 40.
Yeah, absolutely. Thanks a lot. Yeah, thanks a lot for having me again back. I'm very excited to explain you the topic that we're looking forward today. So whenever you like, I'm ready.
Perfect. Thank you so much. As I mentioned, we will talk about IVF for women over 40. And of course, we will talk about your treatment options. And of course, we will talk about age here. So, of course, as always, remember to put your details in the chat with your questions in the chat so that Dr. Elena can answer them for you. We will start with her presentation as always, but of course, there will be time for the questions. So you can do it during the presentation or afterwards, and we'll be and definitely happy to answer them for you. So don't hesitate. It's all anonymous. So you can ask anything that's on your mind. And I'm sure it's going to be a great session, as always. And just to remind you, Dr. Elena is the gynecologist and fertility specialist at Vida Fertility, as I've mentioned. And I'm really happy to have you back. And I think we can start off with our presentation. I have it right here as well. So whenever you're ready, Dr. Santiago, we can start.
Okay, thank you very much,
Thank you
Caroline.
so much indeed.
So thanks a lot for being there today. As Caroline said, I want to talk about IVF for women over 40 and understand what will be the options. Obviously, it will depend in each case. We need always to individualize, but in general, in overall, I can give you some ideas. Um, I have more than 10 years of experience. As Caroline said, I come from Vida Fertility. We are in Spain, but we do have two clinics in Madrid and another one in Alicante. I'm in Madrid right now. And well, we are a group of experienced specialists trained in cutting edge techniques and committed to innovation. We have tailored treatments. We take care a lot about dedication between doctor, coordinator, and patient, trying always to be same coordinator and same doctor at all times during all the treatment. We are expertise in remote treatment management because we do have lots and lots of people from abroad coming to Spain to do the treatment, and therefore we do have multilingual support to ensure always a clear communication. We can offer all types of techniques due to the law as well here in Spain, as you know, not only IVF treatments, but also it's easy to get egg and sperm donation. We can offer as well fertility preservation, genetic testing, and also treatment options for single mothers and LGBTQ families. There's also a part where we can offer regenerative medicine, normally with plasma, which we'll talk about during this webinar. So to get started with our topic, why is it harder to conceive after 40, even with already artificial reproductive treatments? And this is because, as you know, in the majority of the cases, because of age, women will have lower ovarian reserve and lower egg quality. So normally this is the main cause. Obviously, it's not all, but we have to think about this always when talking about more than even 35 years old. The ovarian reserve declines within age because we are born with a number of eggs, and this will be reduced over time. We are able to see how the ovarian reserve is with two tests. One would be with an ultrasound. We are able to check the ovaries and see the structures that we call antral follicles. We count them and we say that when we have 10 to 20 antral follicles between the two ovaries, then we consider that we have a normal ovarian reserve. Obviously, lower than 10 will be a low ovarian reserve. And we also compare these findings with the level of anti-Mullerian hormone that can be done in a blood test. The problem is, as well, as we were saying, that the quality decreases. Maybe we have women that have a very, very good ovarian reserve, even above 40 years old, but normally the quality is going to be worse. And therefore, the rate of aneuploid embryos is going to increase. This means that there are going to be more embryos, even if they have a good morphological quality, that will have chromosomical disorders. These embryos normally don't implantate, or if they do, they could provoke a miscarriage during the first trimester. So this is the main reason to explain the lower pregnancy rates and higher chances of miscarriage within age. As you can see here in this graph, we can see how it decreases within age the number of euploid embryos. But it's not only about ovarian reserve. There are also other things that could be affecting, other factors, such as, for example, additional pathologies that can appear with more probability within age. I'm talking about endometriosis, fibroids, polyps, and also other general diseases as hypertension or diabetes that could decrease the chances and have an impact on conception and the progress or normal progress of pregnancy. We are always talking about women, but we also have to see if there's an impact in the male factor in men within age. It's true that it's not the same because they are capable of creating new sperm each 3 months. This is the duration of the sperm cycle. So therefore, they don't normally have this problem of low sperm count, for example. It's true that age could affect in concentration, motility, and all this, but also we have to consider one important thing is that within age, there are more oxidative processes that are going to affect the quality of this sperm, meaning that, for example, the DNA fragmentation can be higher, and this could affect the fertilization rates of the eggs, the normal development of the embryos, and even decrease finally the chances of implantation. We can find out about DNA fragmentation with a test and see if we need any therapeutic solutions, such as, for example, sperm selection techniques before doing the microinjection during an IVF treatment. Sometimes if fragmentation is very high, maybe it's more interesting in giving antioxidants to that men so that they can decrease a little bit the fragmentation before going ahead with the treatment. And sometimes if we are not able to decrease this fragmentation and we go ahead with his sperm, then maybe we need to do PGTA testing as well. It depends, okay? Now I want to talk about the solutions that we can offer to become a mother over 40. So one of the new things that we can offer is the ovarian rejuvenation. This is a treatment where we use your own platelets growth factors, which will be introduced directly in the ovaries during an easy procedure, very similar to the one that we do when we do the pickup or the egg retrieval. This needs to be done in the follicular phase of the previous cycle to stimulation, and is suitable for women under 45 with a low ovarian reserve. So the aim of this technique is to try and increase AMH levels, antral follicle count, so that we can have as much more eggs as we can during the IVF on the next month. It's true that still is an experimental technique. We need more evidence, but we've been already several years using it. We do have already some results. It does work, but sometimes not always. And we need to see furthermore what will be the results in general to say if definitely it's working or not. But it's true that we are already using it. Another technique that we normally offer is the PGTA testing of the embryos. This is a biopsy of all good quality blastocysts that we achieve. These embryos are in day 5 or day 6. And it allows us to see the chromosomes, let's say, do a karyotype of the embryo with a reliability of 90%. Is normally suitable for women over 38 years to improve success rates after the transfer. It therefore increases the chance of a healthy baby by reducing the risk of chromosomical disorders and miscarriage during the first trimester. And another thing that I wanted to talk about that's working quite good, and we normally offer to women over 40 that want to try IVF with their own eggs, but they normally have a low ovarian reserve, or the quality is not very good, and we are not able to achieve lots of embryos at once, is the technique called the dual stim. So this is doing 2 stimulations all together in the same menstrual cycle. We start with a normal menstruation, let's say, with a normal stimulation, with the menstruation in that follicular phase of the cycle, and we go ahead with the egg retrieval as always. But in this case, 5 days after this first egg retrieval, we assess we assess how the woman is feeling. We do an ultrasound to see the ovaries, check that everything is fine, to go ahead with a second round of stimulation in that luteal phase of the cycle just after ovulation. This works because we know that there are several waves of recruitment of new antral follicles. Not only happens when we have the menstruation, it also can happen before ovulation and after ovulation. So these are going to be new follicles that appear at the ovaries. Why do we offer this possibility? It works quite good. It's really good accepted by patients. And it helps us to increase in total the number of eggs collected, and therefore finally the number of embryos and blastocysts to be biopsied, for example, for our PGTA testing. The higher the number we get, the higher the chances will be to find a normal chromosomic embryo or euploid embryo. It also reduces the costs compared to 2 stimulations in different cycles. First of all, because we can use medication that we've used in this first stimulation that was left over, and that if maybe we keep it for a new cycle at another time, maybe it's not going to work. Let's say that that medication sometimes maximum has, and we can use it during 1 month after it has been opened. It also reduces the costs because we can send all together all the biopsies of all the embryos achieved from the first and the second round. And therefore, we can offer better costs to our patients if the idea is doing a dual stim rather than 2 cycles at different times. And also, we don't know exactly why, because it's true that there are many studies already done for the dual stim, and they say that the response is similar between the two moments of the cycle. The number of embryos or eggs achieved is similar as well when they do the studies all together. But it's true that we find out that many patients in this luteal phase have a very good response, even achieving more eggs and therefore more embryos than in the first round. There is also a very important thing to take into account, that is that there's no differences between embryo quality or euploicity, and this is proven as well in all the studies that have been done until now. This is what we can offer for IVF treatments, but obviously the main treatment that at least can give us more pregnancy rates is always going to be the ectonation. This is a treatment that is always there. I say to my patients, look, this treatment will always be there. The pregnancy rates won't change within age. We can always try and last IVF before going to ectonation, but obviously ectonation will give us more guarantees as well, because we can guarantee that we will achieve blastocysts of good quality to be transferred. This is not the same as with IVF treatments. How does it work? Well, so this type of treatment will be always indicated for those patients with very low ovarian reserve, very low quality. After several IVF treatments that didn't work, that's when we normally consider that it's the time to move on and go ahead with egg donation treatment. In Spain, egg donation is going to be always anonymous. We have our proper donors at our clinic. We follow up obviously the law and all the recommendations made by the Spanish Fertility Society. These women will be pre-selected. They will always be aged more than 18 years and less than 35, normally even less than 30. By law, they can maximum have 6 children born from the same donor, even taking into account proper children, and this is per country. We make sure that they are healthy, obviously. We are going to do many medical consultations psychologically to make sure that mentally and physically they are healthy. We are going to obviously check always that there are no transmissible diseases, as well as the sexual transmitted diseases. And we also will do some genetic testing. This will be a karyotype that needs to be normal, and the 7 recessive mutations that will be the most frequent ones, such as cystic fibrosis, will be checked, and the donors will be negative. Then the selection needs to be done regarding physical characteristics. We will try and find a person the more similar we can to the recipient, to the patient, and as well we offer the possibility of doing a larger panel of recessive mutations, but in this case we do need to do the same pack of mutations to either their couple, if we are using its own sperm, or if not, to the donor. So we make sure that we select a donor that has genetical compatibility. This means that they don't carry the same mutations as their couple or the male donor. The treatment, how does it work? Well, we can always offer fresh embryo transfer or frozen embryo transfer. It depends on the case. Normally, we do frozen embryo transfer because it's easier logistically, meaning that we will ask for the men to come and give the sperm sample, first of all. Sorry. And then once we have this sperm normally frozen, if obviously the conditions allows us to have this frozen sperm sample, meaning that normally we have a normal sperm sample, men are aged less than 45 years old, we can use it frozen without any problem and without affecting the pregnancy rates. In this case, it's easier for them because they can come whenever they want or they can. They give the sample, then we wait for the donor to do the treatment. We do the fertilization with a frozen sperm sample. We wait for 5 to 6 days to obtain the blastocysts, and we freeze them. After that, when we make sure that we have embryos of good quality, that's when we will go ahead with the endometrial preparation of the women or the woman. This endometrial preparation can be done with a substituted cycle, meaning taking estrogens, normally orally or with patches, and afterwards we will always need to add progesterone. There's also the possibility of doing a natural cycle preparation. This obviously depends on each woman. If they have regular cycles, we can go ahead with it, but it's true that we are not able to fix a date for the transfer. We need to see how the natural cycle is working by itself, when we can have a good endometrium size and aspect, as well as have a dominant follicle, so that we can decide when to provoke ovulation and just a week after come for the transfer here to Madrid. There's also, as I told you, the possibility of doing a fresh embryo transfer. This doesn't mean that it's going to be better and that we are going to have better chances, but it's true that maybe it's an option to consider when patients live very, very far away. They normally decide to come for 1 or a couple of weeks here in Madrid. Obviously, we will have already the donor selected, and the woman will already be with her endometrial preparation. So we make sure she's ready. We go ahead with the donor egg retrieval, and 5 days after, we do the transfer in fresh. So things to conclude today. I want you to take some ideas home. It's very, very important that you understand that the ovaries have an optimum time to operate, so the sooner the better. Fertility and reproductive outcomes always depend on women's age, and we should be aware of it to decide the best treatment for each patient. Normally over 38 years old, we should also add PGTA testing to IVF to increase the pregnancy rates. When ovarian reserve is very, very low, we should try other options, such as plasma treatment and or dual steam, to try and achieve as many eggs as possible. Whenever the above didn't work, as we said, we can always consider egg donation as the solution, or normally it's directly the indication for women above 45 years old. And before I finish, I would like to see with you or explain, how your patient journey could be at Vida Fertility. Just the steps that you will need to go through. First of all, we normally need an initial medical consultation. This could always be online or on site. We ask you to do the missing exams. either at home or come at our clinic to complete your medical file. Then we will make a personalized treatment plan for each patient, see when the sperm sample needs to be given, see if we need any regenerative medicine, do the donor matching, and finally look forward for the ovarian stimulation and egg retrieval, the donors or yours, see if you need an endometrial preparation, all this. Then we will do all the work at the lab with in vitro fertilization or of own eggs or donor eggs, the embryo development until day 5, day 6. This is important because we always work in a blastocyst stage. See if we're doing a PGTA testing or not. And finally, see when we do embryo transfer, which can be fresh or frozen, as I've already talked to you. So thank you very much for your attention today. If you have any questions, please don't hesitate. I'm here to help you. I'm available, and very nice to meet you all. And well, if you need any help, we are here to give you that help, and together get to your dreams of having a baby.
Thank you so much indeed, Dr. Santiago, for your presentation
Thanks.
and explaining all the steps that you can take and, of course, what options are available. We will go for your questions, so keep them coming. Of course, I see more questions are right here as well, which is good. Thank you so much. We are here for those. So it's about embryo adoption. So do you also offer embryo adoption at Vida Fertility?
Yeah, we do. We have that opportunity, and right now we do have embryos always at a blastocyst stage. But it's true that well, it's always a possibility, but pregnancy rates are always going to be a little bit lower than with egg donation treatments.
Can you explain why is that? Just to let our patients
So
know.
you have to consider that these embryos are the ones that are left over at the bank after normally patients achieving a pregnancy, and therefore they decide that they don't want to try again, and they give their own embryos for donation. It's true that one of the requirements is that women have always to be aged less than 35 years old whenever they've done the treatment when achieved these embryos. So this is the same as egg donation. But sometimes couples come from or fertility problems. It's true that they've achieved normally a pregnancy, but maybe these embryos left over have a lower quality. I mean, it's not it's not bad at all, the pregnancy rates that we can give. It's around 50%. But also the testings to the patients maybe are not the same to egg donors. So more or less that's the reason why pregnancy rates can be a little bit lower.
Okay, thank you so much, crystal clear, I believe. Now we have a question about mini IVF for 40-year-olds, and does it make sense? And by mini IVF, I mean stimulation with Clomid and menopause. This is the question. I can show it to you, sure.
Yeah.
So mini IVF, does it make sense?
Mini IVF, okay. Does it make sense? Well, as I say, we have always we need always to individualize each treatment. Maybe it's not the first option that we normally use for an ovarian stimulation, but if we've already tried with maximum dose, other medication, and we see that it doesn't work very good, it's true that maybe for a second round or third round, we can try to do a mini IVF, understanding that this means mild stimulation, and adding up the clomiphene is always a good option for sure, if we're not doing a fresh embryo transfer.
Okay. Thank you so much. Let us know if that answers your question. I do believe so, but if there's anything else, you know what to do. All right, next question. I know doctors don't like to talk too much about cost, but someone actually asked what is the total cost for someone coming from the US and is 45 when it cost for the IVF, sorry, treatment, of course.
So, I mean, it depends obviously in all the options that we consider for each patient. Let's say that the lowest price would be around 4,000 euros. Highest price is if we are not using PRP, PGTA testing, time-lapse incubator. Maybe the price could get until 8,000 euros, something like this. This is for IVF. For egg donation treatments, it's similar, and I believe that the maximum price would be around 10,000 euros when using PGTA testing as well.
Of course, just to clarify, if you wish to get more details, it's always best to directly contact the clinic. I believe there was an email in your presentation. I can show it to you, of course, after we finish with the questions, so you can see it, and that will be best, I think, just to get the cost. All right, thank you so much. Regarding dual stimulation, so what are the chances of ovarian hyperstimulation syndrome? This is our question.
So again, obviously it depends on the basal situation of each patient. Normally, if the ovarian reserve is good or high, meaning that we have risks of hyperstimulation, we normally don't offer the possibility of doing a dual stim, beginning with the idea of achieving loads of embryos with this type of patients. So there's no need to do this dual stimulation. This is normally necessary, or we can offer it to patients that have low ovarian reserve. So there's no hyperstimulation syndrome in this type of patients.
Okay. Again, thank you so much. I hope that answers your question. And you already kind of mentioned this, but is there any hope for a 45-year-old lady with no period currently and no AMH?
So unfortunately, because of age, I don't think that PRP would work. It's true that sometimes this situation in a younger patient, with premature ovarian failure, we can try PRP because the quality of the eggs would be a little bit better. But from 45 years onwards, as I said, I think this is not an option, and I believe that the best option will be to consider egg donation directly.
Okay. Thank you for your advice here. Yeah, actually, I'm just reading the comments, and the same patient just added already done PRP and it didn't work. Yeah, like you said that.
Yeah, I'm sorry, but well, at least you've tried, you've seen. So I believe that the next step is egg donation. I know it's not easy, but in the end, we have loads and loads of patients that achieve their babies with egg donation treatments. And well, making the decision is the most difficult part. Afterwards, everything is going to be easier.
It's definitely a process that you need to go through, and it's not a decision that you take from one day to the next. I think, yeah, you just need some time also.
Yeah, that's it.
Thank you so much indeed again for that. Now I will show you the question. There are some things here. So what antioxidants do you normally recommend for sperm with high DNA fragmentation? 51%. Would those antioxidants be able to bring down the level of fragmentation?
So what we've seen until now, obviously, it's good that we combine antioxidants such as DHA, such as zinc, which normally, all these vitamins that they sell for fertility in men, normally they contain all these type of antioxidants. But also it is very important that we add a treatment with curcumin, because we've seen that this helps a lot to lower DNA fragmentation So, well, normally it's true that also you need to be very constant with the treatment. At least to see a good change, you need to take it for at least 3 months, because as we've said, this is the duration of the sperm cycle. And obviously, if there's any need to change life habits, you need to also take this into consideration, because imagine if a man is a smoker and it's doing the antioxidant treatment but still keeps on with smoking, then maybe we are not going to find many changes there. So it's a combination between antioxidants and life habits.
Sure. Thank you so much. And there's actually one more thing from the same patient regarding this. So let's have a look. What sperm selection techniques do you use for sperm with high DNA fragmentation? And would sperm selection be necessary if donor eggs were to be used?
So techniques, it depends, first of all, in the type of DNA fragmentation that is high, meaning double strand or single strand DNA fragmentation. For double strand fragmentation, we normally use techniques such as SIMOD, which is the same as fertile chip, if you've maybe heard about the other one. For single strand fragmentation, we normally use a technique called sperm slow. But it also, as I say, depends on the quality the day of the sperm collection, because sometimes, because of density reasons, motility, concentration, we are maybe not able to do the SIMOD, which was the one that we have indicated, and we need to use, however, the other one. Well, no problem. At least use one of them, and depending on the results of the DNA fragmentation, decide which one would be the best for each patient or each case. And then the question was, do we need to do it with donor eggs? Okay, it's true that these eggs are of better quality normally and are capable of repairing some of this DNA fragmentation from the sperm, but not always. So if we do see that DNA fragmentation is high, we need to use the techniques as well, so that we get the best results with egg donation treatment as well.
Okay, I think that again, that answers your question. If there's anything else, you know what to do. And Belinda would like to know in regards to for egg donation. I worry that there won't be donors of Indian origin. Do you have such donors?
So that's true. Some of the origins is really difficult to have donors. Obviously, it depends on the culture, or if the country is very far away. It's very difficult to get donors from there. But you have to think that nowadays, worldwide, there's such a mixture of ethnicities that what we look at is, in this type of cases where we don't have the same country, we look at physical characteristics. So we do have people that maybe come from other places that look similarly to you, from another background.
And especially that I think that lots in Madrid, for example, I guess
Yeah, absolutely.
Yeah, that's what I
I
keep
mean,
that. It's
today we
quite
are
diverse, right?
at every place. So all the ethnicities are mixed. Obviously, we need to look at something similar. But yeah, we've had patients from India. Well, in general, Asian patients is very difficult to get donors. But in the end, we find people from other places that look similarly, because their background is from that same country, for example.
Okay.
Yeah.
I hope that helps again. Thank you so much indeed. All right. Do donor eggs have the ability to repair some of sperm DNA damage?
Yeah, so that was mentioned before. It's true that donor eggs, because of the better quality, have this ability, but I don't believe that they repair it all. I mean, I've already had cases where you do an egg donation treatment thinking that the sperm is perfect. normal sperm count, you go ahead and you see that fertilization rate is very low, and you even don't get a blastocyst of good quality. And after you assess DNA fragmentation and you see that it's high. So therefore, this gives you the evidence that even if we neck donation treatment, we do need to use the sperm selection techniques as well.
All right. Thank you. Thank you so much once again for that. More questions are coming up, so thank you for those. What is the ideal sperm count? AD, this is the question from her. What is this ideal sperm count?
So normally we will follow like a worldwide parameters of the World Health Organization. So the best concentration would be to have above 32 millions of sperm in the same sample. Obviously, it depends on the volume of each patient. It even depends on the day of the sample, but well, this is the normal parameter.
Okay. Is it useful to use embryo glue the first time doing IVF if we are 42? This is, yeah.
So until now, the evidence that we've looked at doesn't prove that it's better to use embryo glue when doing an embryo transfer. So in our opinion, or at least in our lab, we don't normally use it because we are not sure that it really helps for the implantation to take place.
Okay, crystal clear again. Let's have a look. Okay, there are some background information here as well. So some details, let me just show you. So for someone who had several failed frozen embryo transport cycles with embryos made from donor eggs and donor sperm, is it possible that her endometriomas on ovary and severe endometriosis caused inflammation and immune problems, thus affected implantation and pregnancy? Is it good or bad to add steroids? NK cells were tested in uterus and are normal, but not tested in blood. And the patient is 40. Anything you can advise here?
Yeah, so for sure, after several embryo transfers of double donation without success, we need to have a look at other factors. It's true that one of the factors is related always to the immune system. Endometriosis, we know it gives inflammation, and therefore also the immune treatments such as steroids can help to decrease that inflammation and do the endometrium to be more receptive. But obviously, this needs to be followed up by a specialist, normally an immunologist, and we need to make sure as well that other factors have been already looked at, such as the uterus, that we have a good cavity with a normal morphology. We normally check as well endometrium, see that there are no infections over there, see if we need to look at as well window of implantation, and for sure combine this with immunological treatments. I think is a good idea in this particular case.
Again, thank you so much. I hope that was helpful as well. Of course, if you have anything else you would like to add, you know what to do. You can type the questions in. If not, we will be finishing for today. But of course, you can always get in touch with Dr. Santiago and her team at Vida Fertility Institute. I'm sure they will be able and happy to help you out. And I believe that was our final question for today. So someone is typing. Let's give it a second, but we will be finishing slowly. So Dr. Santiago, thank you so much. Welcome back. I hope you are also happy with how it went. I think that there were lots of different questions and it went very well. So I'm really happy to have you back. Anything else you wish to add? There is a thank you for detailed information. So anything you wish to add before we finish?
Thanks a lot. The aim, finally, our aim is not only to help during this type of treatments, which we know that emotionally are very difficult. We have lots of expertise in complicated cases where patients have been already through artificial reproductive treatments after even years. So that's the reason why we know that coming abroad from other countries is sometimes also a very difficult decision. We always want to be in contact, have that sensitivity not to patients, be with them by the hand during all the process. And for me, it's very, very important. As I say, each case has their own particularity. We need to individualize always. And as well, I believe it's very, very important that they understand where they are, what they are doing. So information is really, really, really important to be given. And sometimes you can give information and let patients to take their own choice of what they want. But the base of everything is that they are well informed so that they can choose whatever they prefer.
Excellent. Thank you so much. Great finish, I think. So thank you so much for that. And of course, as you know, we will be back with some more events. So stay tuned. We will be back actually tomorrow. There is an event with our new host. Probably you already had a chance to participate. Ask Your Doctor an Ask Your Doctor event is coming tomorrow, so you can join us. Go to our website, My Every Fences. You will find all the information there. And thank you so much, Dr. Santiago. I know it's not our final webinar, so I'm really looking forward to some more events with you. Thank you so much for your time. And everyone, thank you again. And I hope to see you here back soon as well. And best of luck as always. Thank you. Take care and have a good evening. Thank you.
Thanks.
See
You
you.
too. Bye-bye.
Bye.
See you soon. Bye. Thanks.